Morning everyone, Dr. Eric, the fitness physician. Welcome to my channel. This is where I talk about all things related to health and hormone optimization, muscle medicine, and hormonal fitness. So continuing on with Thyroid Thursday, we're going to continue talking a little bit more about thyroid, some of the chemical pathways we talked about before about how T4 converts into the active component, which is T3, which is the more metabolically active form of the thyroid hormone in your body. I'm going to do some PowerPoint presentations in the future and kind of go through these chemical pathways for the guys and gals who really want to get into the science. But we talked about how T4 is converted into T3. That's what we want. That's the good conversion. The bad conversion is when it gets converted into reverse T3. It has the opposite effects, like I talked about in the last video. Not good. So what we want is that because it's going to T3, and this can be affected by mostly lifestyle factors, nutrient deficiencies, and much more. So there's a 5' deiodinase and a couple other deiodinases, D1 and D2 and D3, and again, I'll talk about that in the future, but these deiodinases basically take off an iodine molecule. That's what this means. It goes from a T4, which has 4, into 3. Basically, it basically converts it. So that's what happens in the body. So that's the main chemical pathway that you'll see throughout the body. Now, then a little caveat is in the brain, T4 crosses the blood-brain barrier, and then once in the brain has plenty of this deiodinase to convert it into T3. T3 does not pass over, so that's why it's important to make sure both hormones are optimized. So that's most of the time when we give patients Armour Thyroid or Nature Thyroid, or basically a compounded preparation which has T4 and T3, and we can customize the amount of each to tailor it to get what we need, because sometimes the body needs more T3, other times it needs a little bit more T4, and sometimes it just needs equal amounts of both. And that's why the commercial brand sometimes just doesn't cut it, because it just has T4. And if your body's not converting it properly, it's not going to work in the body. Maybe it's getting to the brain, but it's not getting elsewhere. So we have to fine tune it. So it's a little more complicated than that. But that's an important point, is that it has to cross over. You can't just, the T3 will not do it. So anyway, so again, like I talked about before, I want to treat the patient. I'm going off their symptoms. How do they feel? Are their symptoms improving? Is their quality of life getting better? I don't really care too much about the numbers, because those are more of a guide. Again, we have to focus on the patient. We've kind of lost that in the art of medicine of late. I'm trying to bring that back. So, but in general, people are always asking it. Sometimes it's good to get a baseline to see where we're at. But free T3, roughly, and it varies from laboratory to laboratory. Anywhere from 2.3 to 4.3 is where we want. I try to shoot for around 4. Sometimes 4.5, depending on the patient, but that's usually optimal. TSH range is anywhere from 0.3 to 5 or 0.3 to 2. Those ranges have changed, and again, there's a ton of individual variation. A lot of these ranges were based on population statistics, whereas the individual statistics are highly variable. And again, I don't want to get into the statistics right now, but there's a huge range. And again, that's why it's important to focus on the patient. Free T4, anywhere from 0.8 to 1.77. Again, we try to get right around 1.1 or so as an optimal range in general. But again, the most important thing is the free T3. Treat the symptoms, and then of course follow the ranges as needed. Not too worried about the TSH because it has other, it's just not a good marker of optimal cellular thyroid function. And we'll talk about that again later. And you look back at the historically, and a lot of the experts in the field like Broda Barnes and these other physicians have realized that TSH is not that important, because there's different deiodinases in the pituitary gland that control this versus the deiodinases in the body. It's highly complex. It took me a while to grasp it when I read this, but I'll do a PowerPoint on this in the future. But again, there's important distinguishing characteristics there, is that in the brain or in the pituitary it's quite different, and it's more of a marker, right? Again, we have to focus on the cellular. Again, that's what I talk about: cellular nutrition and fitness, right? Cellular medicine and cellular hormonal fitness. So the free T3 has to work on the cell, and if the receptors are not working, the conversion is happening. What we can have is what's called cellular hypothyroidism or cellular hypometabolism. Dr. Starr, Dr. Barnes has written books about this extensively, and the fact that TSH doesn't measure this, but you can have plenty of thyroid floating around in the bloodstream, and all your levels are good, but it's not getting into the cell. It's not working at the cellular level, so you have all the symptoms and all the problems associated with it, and therefore you have to fix it. Therefore, that warrants a trial of thyroid therapy. So anyway, we'll talk about that more in the future. So if everyone enjoyed this, please like and share my posts. Find me on YouTube, Instagram, and Facebook, Dr. Eric Primex, the fitness physician, Primex Cellular Nutrition and Fitness on Facebook. Please share. If there's anything you want to learn about, read about, tag me. I also have a great joint program with Ali Gilbert. We have a double combination consultation. We get both of us to get the best of both worlds, where we get all hormonal fitness, all the medical side, hormonal optimization, nutrition, and fitness from Ali, and we will tag team and optimize your body to unlike anybody else. So call us, reach out to us, and let's get your body and get your health back. Everyone have a rocking day. We'll talk to you soon.